All right, we're live, Randy.
Thanks, Nitesh. All right, hi everyone. Welcome back to another edition of Tumor Talk. This is the joint collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we highlight recent publications in the Journal of Neuro-Oncology, talk about the rationale, the results, and the relevance of these studies. Today we have a special edition. It's part of our ongoing series where we highlight some of the award-winning abstracts in neuro-oncology from the previous year. And today's session is all about skull base. And so we have three special guests with us, Dr. Michael Link, Dr. Gautam Mehta, Dr. Michael Catalino, right? Am I saying that right? And I'm going to let them each introduce themselves and what they do and what they've studied. And, we'll try to move pretty quick. We try to limit it to about 30 minutes. So feel free to ask questions in the chat and or over Instagram. We're monitoring that as well. So welcome, guys. Michael, why don't you start?
Which Michael?
Dr. Link.
Okay. Thanks. I'm really delighted to be here. Thanks for the wonderful opportunity. Let me fix this. Can you see my title slide there?
Looks good.
Okay, great. Thanks everyone. My name is Mike Link. I'm one of the neurosurgeons here at Mayo Clinic in Rochester, Minnesota, which is a very cold place to be from. And really, I would say that a large part of my career has been involved in the management of vestibular schwannoma. And we were actually fortunate enough to host the 8th quadrennial meeting of International Meeting on Vestibular Schwannoma back in 2019. And we really got thinking about some of the controversial issues regarding vestibular schwannoma management. I'll say I don't have any disclosures. And certainly I'm going to say this is maybe a popular topic, given that we're kind of in a time of divisiveness. But, long before things got really out of hand, actually, there's been a lot of controversy, a lot of debate regarding vestibular schwannoma. And it certainly goes all the way back to what all of us would consider to be the founding fathers of neurosurgery in North America, between Harvey Cushing on the left and Walter Dandy on the right. One of the big rifts in their famous collaboration and friendship and mentorship was regarding vestibular schwannoma. And I would say, I don't think there's any controversy about a case like this. This young man I saw and operated about 10 days ago. He showed up with this giant tumor in big trouble. And I don't think there's any question this patient needs surgery. But, and amazingly, I'll just add, he actually had quite good hearing in that year, if you can believe it. But regardless, everybody would say he needs an operation to have that tumor removed. Now, this is where things get a bit more controversial. So this is a 54-year-old woman. She has very mild left-sided sensorineural hearing loss on the background of some kind of bilateral hearing loss. And she appropriately got an MRI scan because her hearing loss was somewhat asymmetric. And they found this small little tumor here. And so I don't doubt there must be somebody in the audience who would say, well, now is the time to act when the tumor is at its smallest. Some people would say now is the time to treat with radiosurgery. And I think some people would say, just observe it. In fact, this tumor was observed. And if you fast forward to a couple of weeks ago, this is what the tumor looked like. So 3.5 years, considerable amount of growth. And so I would bet now most people would say treatment is very reasonable, but what treatment to do, of course, is where things get controversial. She still has quite good hearing. She has decreased hearing in the left ear compared to the right ear, but still 90% speech discrimination score. So what we really set out to do was address the variance in clinical care surrounding sporadic vestibular schwannoma. And basically, we used a modified Delphi process. So what we did is we enlisted 16 experts from 4 stakeholder societies. So we asked the American Academy of Otolaryngology head and neck surgery, and Roberto Cueva from Kaiser in San Diego, Richard Gergel, who is an otologist at Utah, and Walter Kutz, who's an otologist at UT Southwestern. From the North American Skull Base Society, Severo Agazzi, who's a neurosurgeon at University of South Florida, Darryl Brackman, who's quite a famous otologist from House, and John Golfinos, who's a neurosurgeon at NYU. The joint section of the AANS CNS tumor section, Fred Barker, who is a former chairperson, and Jason Sheehan, who's the current chairperson. We asked the International Society of Radiosurgery, and they recommended Doug Kanzioka and CPU, who's at Hong Kong. And then the organizers, which included my otology colleagues, Matt Carlson and Colin Driscoll, as well as David Haynes, who's an otologist at Vanderbilt. And then we also included Brian Neff, who's one of the other otologists here, and Jamie Van Gumpel, who's one of my partners in neurosurgery. So we had 8 neurosurgeons, 8 otologists. 5 of the neurosurgeons had extensive experience with radiosurgery. And we considered strong consensus when there was greater than 80% agreement among the panel, moderate consensus when there was greater than 2/3 agreement, and no consensus if we couldn't get at least 2/3 agreement. All voting was done anonymously, and we required full participation of all 16 panelists before we could move on to the next round. And this is basically what the process is. And without getting too much in the weeds of this, basically the 4 of us, me, Colin, Matt, and David Haynes, basically came up with every question we could think of that we thought was controversial and relevant. And then we put those questions to a 16-member, to the full panel, and said, is this question relevant? Is the wording of our question or statement clear to avoid any misinterpretation? And what else do you think we should be including? And then we had quite a long conference call where we went through all these statements. And we basically came up with 103 statements that we thought were a reasonable things to consider. And then everybody voted. And the voting consisted of multiple choice questions. So we would say something like, the chance of preserving hearing in an intracanalicular tumor performed by an experienced surgeon is 70 to 80%, 40 to 60%. 30 to 40%. And then there was also a place where they could write in other if they felt strongly about some other. And then we assembled all of that and then did a second round of voting. And then we had another conference call where we looked at all the results and had the third and final round of voting to come up with what we thought the answers to these statements were. And in order to make sure that it was a very transparent process, after each round, a summary of the anonymized responses, comments, and revisions were sent to all the panel members so they could look at it, which is kind of an interesting process, right? Because it allows some crowd think. So if you're very set in your way about a specific issue, this kind of lets you know what everybody else was thinking. And so it's kind of interesting to see how the barometer moved on some of these more controversial issues. So of our 103 items, 49 had to do with hearing preservation, either with radiosurgery or microsurgery or observation. 20 were regarding tumor control or imaging surveillance. 24 were regarding preferred treatment. 4 were regarding just operative considerations, and 6 were regarding management of complications. And after all of this, I was frankly amazed that we got strong consensus, meaning more than 80% agreement in 96% of the statements. And the remaining 4%, we got moderate consensus. So there was no statement we couldn't get at least moderate consensus, and most of them reached strong consensus. And then to validate this, to prove that it wasn't just the 16 of us all convincing ourselves of something, we offered these 103 statements to the 240 attendees at the conference that we hosted here in Rochester. And 79 of the attendees filled out the survey. And we got strong consensus on 71% of the statements, moderate consensus on 20%, and there was only 9% where we couldn't get complete consensus. So we were quite, I would say, happy to show that you can really get strong consensus on the great majority of these contentious issues using this modified Delphi process. We published this in Otology, Neurotology. That a special issue dedicated to the meeting that we had, which came out just in December of last year. I want to acknowledge Christine Losi, who's in our Division of Biomedical Statistics and Informatics here at Mayo, and Heather Billings and Alyssa Hall, who are really, frankly, experts in this Delphi process here at Mayo Clinic, and they helped shepherd us through this process. So I'll stop there. I don't want to take any more time, and I'd be happy to answer any questions about what we did and why we did it and what we found.
Thanks so much, Michael. Obviously, a great study. It's a shame it wasn't published in Journal of Neuro-Oncology, but but the abstract at least won the award, and I think Dr. Sheehan obviously was involved and knew about this. So, I mean, what is your interpretation of? I mean, obviously the study is a great study. These Delphi studies, I've actually seen them play out in a number of different fields, from pediatric neurosurgery to spinal neurosurgery and brain tumor. What do you think it shows you about kind of the multidisciplinary aspect of treatment of these diseases, right? This is a disease treated by ENTs, neurosurgeons, radiation oncologists, and the fact that there's so much consensus in terms of what we're doing.
I think one thing that's really encouraging in all of this is that it sure seems to me that we are all following everybody else's literature. In other words, the people who primarily do radiosurgery are very up to date and in tune with what the surgical literature is saying and vice versa. And the neurosurgeons very much knew what's out there in the ENT journals, and the otologists knew what was in our journals. And I think that was one of the more gratifying things that came out of this. I was very much afraid that we would have camps where the otologists believe one thing and the radiosurgeons believe one thing, and the neurosurgeons who primarily only did surgery in our group would believe one thing, but it really wasn't the case.
Yeah, I think totally fascinating, and obviously a lot of great minds moving the field forward with that, or at least keeping it stable and where it is, and that's great. In the interest of time, I mean, I'm sure there are plenty more questions, but we'll keep moving through. Gautam, you want to go next?
Stop share.
Yeah, perfect. Let me share my screen. All right. Y'all see that?
Perfect.
Okay, great. So thanks for having me and for the opportunity to present some of these findings from work I did at the House Clinic related to physical exam and vestibular schwannoma. These were also just published in Otology and Neurotology in the fall. So I have no disclosures to report. Today I'll review Hitzelberger sign and external auditory canal sensory innervation. I'll then discuss our results from a prospective study of Hitzelberger sign in a cohort of patients with vestibular schwannoma. This study builds on work of Bill Hitzelberger, who was the primary neurosurgical partner at the House Clinic between the early 1960s and early 2000s. With Bill House, he pioneered team surgery and skull-based surgery, and he performed over 6,000 operations for vestibular schwannoma in his career. He also performed the first auditory brainstem implant in 1979. We recently reviewed his career and contributions in the JNS. Seen here. So at the House Clinic in the early 1960s, there were a number of innovations for vestibular schwannoma. And these included the use of the operative microscope for vestibular schwannomas, the first Milfossa approach, first translab approach. And in this pre-MRI era, great attention was paid to the physical exam for these patients. Bill Hitzelberger observed that in a consecutive series of 25 patients with surgically confirmed vestibular schwannomas, all of them had sensory deficits in the posterior aspect of their external auditory canal. And in their experience with the translab approach, they also noted small nerves in the mastoid coursing from the facial nerve towards the back end of the EAC. And this image is from their paper in 1966 on this. So EAC sensory innervation is very complex. The canal is supplied by 5 nerves, including the facial nerve, seen in this image from the Jackler Atlas. We often don't think of the facial nerve as having a general somatic afferent component, but this sensory distribution has been recognized since the early 1900s when Ramsay Hunt described herpes zoster oticus. And for orientation in this image on the right, this is a right mastoid with the incus shown up top, sigmoid sinus down below. And I'm not an otologist, but even I was able to find these small fine branches coming off the facial nerve. They're typically just proximal to where the chorda tympani takes off, which is marked CT. So before moving to house, I had never heard of this before. I first heard about this sitting in some of Daryl Brackman's teaching sessions with the otology fellows. And since, part of the reason for this might be that since Bill Hitzelberger's study in 54 years ago, there's only been one publication about this clinical sign. And this follows the general neglect of the neurological exam for vestibular schwannoma in the medical literature. This is in very stark contrast to the amount of studies that are published, including MRI or CT for these tumors. So I was intrigued by the lack of study on this, and thinking back, the tumors that were resected in the 1960s tended to be pretty large. So perhaps this posterior EAC numbness was not present in all tumors, or more specifically, this may not apply to the small tumors that we now see in the MRI era. So I've hypothesized that the posterior EAC hypoesthesia may be related to vestibular schwannoma size. For this prospective study, since sample size wasn't calculable, I included the same number of patients that Bill Hitzelberger described in his original study, 25. And all patients were preoperative. So we did a blinded test where the physician or fellow assessing the sign was unaware of the tumor side or size when they checked the patient. Daryl showed me how to actually test this. You take a small cut piece of 3/0 nylon suture to stimulate the EAC and the posterior aspect. So either 3 o'clock or 9 o'clock, depending on the side of the patient. You don't need a microscope. It's pretty easy to do. And basically, we asked patients to tell us if there was sensation present there or not, and if it was diminished relative to the other, diminished or equal relative to the other side. But then we recorded preoperative and intraoperative factors after this was done. So I'll summarize the major results here. Seen in the graph on the left, about half of the patients had some sort of sensory loss. One patient had complete anesthesia. So again, that's the group on the right side of this graph are the ones with sensory loss. When we compared size, which is shown on the y-axis of this graph, and again, this is by greatest diameter, these groups were significantly different. And there was no clear size threshold, so it wasn't like tumors over 1.5 centimeters didn't have sensation. There was a little bit of a gradient in between 1 to 2, I think it was high 2 centimeter diameters. And on the right side, I've shown the MRIs from the median tumors from each group, and those are represented by the red dots in the graph. We also found that sensory loss was a significant predictor of superior vestibular nerve origin confirmed at surgery. And finally, we didn't find any association with facial nerve outcome. So as an explanation for these findings, we suggest that larger tumors may be more likely to compress or stretch the facial nerve, causing the sensory loss. Additionally, since the superior vestibular nerve is located adjacent to the facial nerve in the distal part of the IAC, tumors from this origin may cause more compression of the facial nerve in this location. I tried to illustrate this below. The example in the middle is showing that compression by the adjacent superior vestibular nerve. So, obviously this isn't going to replace MRIs or audiograms, but maybe it has some role in clinical study or practice. First, and probably most importantly, given this relationship with size, perhaps this can be an easy to test clinical biomarker for growth. Secondly, many non-tumor patients undergo screening MRIs for unilateral hearing loss. And so maybe this test can be utilized as an additional screening test to minimize the number of MRIs done. And then finally, since this seems to predict superior vestibular nerve tumors, perhaps this can be helpful when considering patients for a middle fossa approach. This is a little limited because in general, these tumors with sensory loss were bigger. So mostly they weren't great candidates for the middle fossa approach anyway. So in conclusion, posterior EAC hypoesthesia or Hitzelberger sign is a significant predictor of larger vestibular tumor size, vestibular schwannoma size, and a superior vestibular nerve origin. And further work is still needed to define how this can be incorporated into either clinical studies or clinical practice. And I'd like to thank the following for their help in the study, particularly Dr. Ann Maxwell, who is one of our neurotology fellows. She's now at LSU, but she did a lot of the testing with me on the study. Thanks.
Thank you, Gautam. Super interesting. I think it's a great study looking at things that, it reminds me of why we all get into this, right? It's using physical exam to identify, pathology, and I think it's a great way to study this. What do you think? I mean, is this clinically bothersome to people when they develop this hypoesthesia? Do people notice it? Do they complain about it?
So I haven't seen anybody complain about it. A lot of these patients didn't even realize that they had this numbness. Even the patient who had anesthesia. Again, there's 5 nerves that cover the EAC or that innervate the EAC, and so I think it's a very small region of coverage that's supplied by the facial nerve.
Well, fantastic job, really cool. Michael, you're up. Oh yeah, sorry, go ahead.
I'm sorry, can I just ask a question? We often hear a lot of patients say that they have discomfort or fullness or pain on the side of their tumor. And classically we say, well, that's not from your tumor probably, but do you think it's from the tumor?
I guess it could.
Is it a dural irritation thing, or could it be from these sensory nerves from the facial nerve, do you think?
It could be. I guess certainly these nerves have some function, and but I think at least what I had observed was more a numbness, and in these patients who had numbness, they weren't necessarily complaining of that pain. So I wonder if most of that is that dural irritation.
Well, great job, man. Michael Catalino, you're up.
All right, thank you, everyone. It's a pleasure to be here. Obviously, Dr. D'Amico, thank you so much for having me. I'll be talking today on corticotropic hyperplasia and Cushing's disease. We all know this disease. Cushing's disease is a difficult disease to treat, often associated with inconclusive histologic findings. This is due to a number of causes, but also in the workup, we often find that MRI can be equivocal. So we really depend heavily on biochemical diagnosis and adjunctive testing. So I think hopefully I can shed some light on this diagnosis of corticotropic hyperplasia today. I have no disclosures. First, I want to thank my mentor, Dr. Laws, and the team, my team at Brigham and Women's Hospital. Basically, this study had equal contribution from almost everyone here, and I really couldn't have done any of this without them. So to start off, I'll just talk about a brief case of Cushing's disease. So here we have a 59-year-old woman with 3 years of weight gain, fatigue, difficulty climbing stairs, hair loss, acne, easy bruising, and memory problems. She had moon facies, hirsutism, dorsal cervical and supraclavicular fat pad enlargement, centripetal obesity, ecchymotic and dry thin skin, and deltoid weakness. Laboratory workup showed mixed results for UFC, the late night salivary cortisol, the DEX suppression test, but ultimately she met criteria for ACTH-dependent Cushing syndrome. An IPSS was performed and showed central elevation of ACTH after CRH administration. And this is our MRI scan. Can you see my mouse here?
Yep. Okay,
so here's a coronal and sagittal T1 post-contrast MRI. You can see an area of basically a hypointense area, not enhancing area on the left side of the cella. You can see it extends posteriorly. And now typically for a corticotrophic adenoma, we see these patients typically have tumors within the central mucoid wedge. But based on older studies, you can see that there's also pro-opio melanocortin cells from the pars intermedia that's distributed throughout in these multiple areas. And this patient had basically an area 4 tumor. Here's based on the biochemical criteria alone and the imaging findings suggestive of a lesion, we did offer this patient surgery. For the surgical plan, we performed a left-sided lesion removal as seen by the shaded area. And then we also took a biopsy of the right side of the normal gland. On the left, you can see the dura with an area, a pale area next to the cavernous sinus on the left, and then the post-resection image showing the normal gland, the cavernous sinus, and the large wedge-shaped resection cavity. The pathology showed from the lesion and from the normal gland corticotropic hyperplasia. And so corticotropic hyperplasia here on the left, where the reticulin stain is, shows intact acinar architecture, but the acini are expanded. This is also associated with the ACTH positivity and TPIT, transcription factor positivity. Both of these were diffuse in this patient. After surgery, the patient had a robust remission response and is currently still in remission 1 year after surgery. She lost 80 pounds and her blood pressure and diabetes have improved. She's now off steroid replacement. So when we talk about pituitary hyperplasia, it can come in many forms. Basically, you can have diffuse focal or nodular hyperplasia. By definition, it's an increase in the cell number without a monomorphic cell population. Diffuse hyperplasia can be seen in somatotrophs, lactotrophs, and even gonadotrophs, and under different circumstances. Focal and nodular hyperplasia is more often seen in corticotrophs and thyrotrophs. Our study looked at 95 patients with suspected Cushing's disease, and we found that 16% of those patients had corticotropic hyperplasia. Their presentation from a clinical standpoint was similar to those with adenoma. Their biochemical profile was also similar except for urinary free cortisol levels. And the imaging findings were more often diffuse or equivocal in patients with corticotropic hyperplasia. Old studies by Dr. Oldfield and colleagues found that in patients with corticotropic hyperplasia, the typical pseudocapsule was not present. So it makes sense that on imaging, the patients were more likely to have a diffuse hypoenhancement of the gland as opposed to a discrete lesion. Our findings are presented here. So total lesion removal, which is consistent with the diffuse lesion, was infrequent, only 33% in patients with hyperplasia, and 65% were found in patients based on extracapsular resection with adenoma. But this did not correlate with remission status in patients with hyperplasia. The initial biochemical remission rate for patients with hyperplasia was 67% and 85% for patients with adenomas. We found that based on an equivocal or diffuse lesion on imaging and what we'd call UFC uncertainty, which is essentially the intuition of the surgeon saying we need multiple UFC evaluations to confirm the diagnosis of elevated cortisol levels. These two variables alone resulted in a positive predictive value of almost 90% and a specificity of 98% for the diagnosis, the ultimate diagnosis of corticotropic hyperplasia. Here's just an example of all the patients with corticotropic hyperplasia in the series and an age-sex matched group of patients with adenomas, showing the differences in imaging characteristics. The pathology here is showing on the very bottom panel, normal pituitary gland. The center panel are patients with corticotropic hyperplasia, and the top panel are patients with adenomas. And this is really important to point out in that based on the H&E and the reticulin stain here shown in the first two rows or two columns, patients with normal pituitary gland will show intact acinar architecture with a relatively uniform size of the acini. Now, there is some significant variability in that, but the ACTH staining is more scattered. In patients with an adenoma, so we'll skip to the top panel, we see complete loss of the reticulin architecture and diffuse positivity with ACTH. In patients with hyperplasia, we see intact acinar architecture, but enlargement of the acini themselves, you can see these are all expanded with diffuse ACTH staining within the expanded acini. And this is a very important finding in the diagnosis. Looking at longer-term survival, so recurrence-free survival, Kaplan-Meier survival estimates are shown here, just showing no difference in the recurrence rates over time. So our study conclusions are presented here. Compared to corticotrophic adenomas, patients with hyperplasia have similar presenting complaints. They have more confusing biochemical profiles. Their lesions are less discrete, both on imaging and intraoperatively, which make the surgical aspects very difficult. And the ACTH positivity with immunohistochemistry showing expanded acini but intact reticulin architecture. The remission rates based on our series were similar, but it was likely related to low power given that there are only 15 patients with corticotropic hyperplasia. And the recurrence rates seem similar. That's all.
Great job. Thanks for presenting. Sorry, we were opening up the discussion to anyone in the audience who wanted to chime in. I mean, this is extremely interesting, right? I mean, it shows you that there is some fraction that's not small of patients who are going to have hyperplasia, not an adenoma. And I think based on the results you're suggesting, my question to you is, does it have any implication for the surgical management of this disease? Obviously we can't diagnose this necessarily preoperatively, but does this push for a more medical management in these situations, or a radiosurgery aspect? How do you view this, or how do your mentors view this?
Yeah, I think that's a great question. I think it really gets down to the our basic understanding of the pathogenesis of Cushing's disease. Over 20 years ago, there was a large discussion, both from endocrinology and neurosurgery, about the origin of the disease, whether it was hypothalamic or it was an intrinsic pituitary problem. And if it was from a monomorphic, cell population, the pituitary, obviously surgery would benefit over medical treatment. But if it was a hypothalamic biochemical problem, a brain circuitry problem, some sort of that would tend more towards medical management, then more of our efforts need to be put towards finding an appropriate, targeted agent to prevent this. And I think that question remains unanswered. I do think that the results of our study show that in patients with biochemical evidence of Cushing's disease with indiscrete preoperative findings, but still meeting criteria, that surgery is beneficial. It's just not as, the outcomes probably aren't as good as patients with discrete tumors. And I think that just is necessary for preoperative counseling for patients. And then it also applies to the surgical approach. I think going in and finding a targeted lesion that's discrete with a pseudocapsule versus doing sequential gland investigation and serial biopsies will help us understand this pathology more.
Hey, Michael.
Yeah.
That's really fascinating. And, the case you showed, and maybe it gets to Gautam's point a little bit as well, is I would have looked at that and said, there's a lesion, and I'm going to go in and take that out. obviously you must have had cases where the preoperative laboratory workup was inconclusive, but the patient has clinical Cushing's disease. What's the surgical strategy if the MRI, truly looks negative? And, do you do 3T or 7T MRI on these patients to try and find a lesion? Do you take out the central inferior gland and the lateral gland? What's the surgical strategy?
Yeah, so that's a great point. So basically, if the imaging findings are completely negative, but they have biochemical evidence of pituitary Cushing's disease, evidence would say that surgery is still indicated. But approaching that patient, like you said, the first part is dividing the gland into sections and exploring sequentially some people have said horizontal incisions or vertical incisions, but exploring the gland for an adenoma. And if an adenoma is not, or a discrete lesion is not identified, then like you said, removing the central mucoid wedge. From additional imaging standpoint, one of the challenges is 7T MRI is really great for the brain parenchyma, but it hasn't shown as helpful for skull-based lesions, true skull-based lesions, especially these tumors which are tiny. The one thing I have noticed, and this has not been explicitly studied, is that the use of dynamic imaging sometimes can be helpful. And I think in particular, patients with lesions either adjacent to the cavernous sinus, potentially lesions adjacent to the cavernous sinus, may be discovered more easily on dynamic imaging, and also vibe imaging, which can be a higher resolution, higher contrast, magnified view of the cell can be helpful. So I think that there's still a lot of questions up in the air, but those are some initial thoughts.
And I imagine you have to rely really heavily on a good neuropathologist looking at the frozen or the smears to tell you, yes, this is abnormal, or no, this is not abnormal.
Right. And I think that the more Dr. DiGirolami and Dr. Meredith were our neuropathologists. They've been doing this forever. And honestly, I think they're some of the best. And I think that it's one of those situations where if you ask a neuropathologist, if you have reports of pathology like this, and you really push the pathologist to make a decision one way or the other, sometimes they will hedge their bet. And I think it's important to challenge each other in that way.
I think it's absolutely great and speaks a lot to kind of the future of treatment for this, especially surgical treatment for this. I think this and Dr. Link, I agree with you. I think pathology plays a huge role in this, and having good, trustworthy pathologists, especially if you're in a center that doesn't have the experience at the center that you're doing this at. Something like Raman spectroscopy, something like artificial intelligence, reading these, pathologic slides is kind of the future of how this can go. And in addition, fluorescence guidance for these types of tumors. When you have a microadenoma with a pseudocapsule, if you can find a fluorophore that can light that up and confirm your place, that's really the future of this. And I think it's possible, but you got to keep doing research. So anyway, listen, great session. Appreciate all your guys' time. We're a little bit over, but that's fine. This will be put on YouTube. You can share it with your colleagues and friends and enemies if you want. And we'll be back probably, I think we're back next week. I'm not sure. I'll post it in the coming days. But great to have you all. Thank you so much.
Thanks, everyone.
Thank you.
Thanks, Randy.
Thank you.
Bye-bye.
Bye.